So what I'll be talking about is the basics and some of the artifacts and nuances regarding OCTA. OCTA as a technology was an evolution of the revolutionary technology that was OCT, but mostly it is adding layers and layers of knowledge to our knowledge, but also introducing a lot of chaos to our imaging nowadays. So we'll just go through the basics, which are not very different. There are four tenets of Octa. That is the detection of a speckle, the scanning of a volume, understanding what decorrelation is, and viewing using ONFAS. So the first we'll come to is what is a speckle detection. Any speckle is a wavefront produced by light. So when when a wavefront or light is reflected off a stationary object, it doesn't vary. But when it is reflected off a moving object, then it produces a change, which is called a speckle. So in principle, this is what happens in an OCT octa. That is, repeated B scans are done on a single point. If there is no change between the 2 points, the outward result is exactly the same. But if there is a change between the 2 points, this is what happens. You get a difference in the wavefronts. And in the eye, the only thing that can change, or the only basic moving object, is the red blood cells. Therefore, the containment, that is the blood vessels, are visualized. So that we come to what is decorrelation. Decorrelation means measuring the change. So this is a small animation that shows at two different points of time. If a blood vessel goes through, you can see its path. However, if the passage is too slow, the machine does not detect it. We'll come to this later. And also, if it is too fast for the system or the threshold, it may not detect it either. What the OCTA does is that it repeatedly measures or analyzes each particular point. And when there is a movement or when there is a difference, that is highlighted, and it is changed to something called a motion contrast image. So the very basis of all OCT angios is this particular concept of the interscan time. It's really simple though important. The B scan, it takes a particular amount of time to scan a particular point in the retina. After that, the OCT has to go back to the initial point and scan it again. So the time for scanning plus what we call the flyback time is called the interscan time. Essentially, it is a time delay between each of these scans happening over here. And why is it so important? The whole sensitivity of the OCT angio to pick up flow is because of the interscan time. When there is a very long interscan time, that is between scans, the chances of it picking up the motion of an RBC is more, and therefore it's called increased sensitivity to motion. However, if in longer scans, they can also be affected by eye movement or eye motion. A shorter scan has decreased sensitivity, that's converse, but the untoward effects of bulk eye motion are not there. Newer concepts like VISTA or variable interscan time, where you can vary the interscan time of a machine between fast or longer scans or smaller scans, are coming up. To summarize this, the blood cells should have moved on for it to be detected by the machine, and it should be around dependent on the interscan time. If the blood has hardly moved, that's a very small interscan time, the movement will not be detected. So there are two concepts here. The first concept is sensitivity. As I said, the longer the time, the more sensitive. However, if there is a faster movement of RBCs and you have a longer time, many RBCs would have moved across, and this particular machine would not be able to detect faster and faster, the difference in faster flows. The next concept in OCT angiography is something called thresholding. Why do you need a threshold? That is, you want to reduce the noise of the system to make sure that noise does not produce an artifactual blood flow. So anything of a low signal is shown as black, and anything of a good signal is shown as a flow. The point is that this is purely arbitrary for each system, and the value is arbitrary. What it also means is that the absence of an OCTA signal does not imply that there is no flow. So why do you need this threshold? You need the thresholding to get a good image. All the bad images are removed, so what you get is only the signal. However, if you have too many low signals or black images, that's called an attenuation artifact. So because of all these things, you can sometimes you can get the presence of flow where there is no flow, which is a false positive, or where there is flow, you may not pick up due to opacities in the system or attenuation. Another important thing about OCT angio is what we call co-registration. When you do an OCT angio, this is the most important thing. You also get an NFAS OCT, you get a cross-sectional OCT, you get a cross-sectional OCTA, and you get an NFAS OCTA. We'll talk about the importance of correlating all these things later. How about visualization? It is the NFAS, that is looking at the top of the retina from the top. What is good about it is that it's the simplest form to understand flow by looking at the top. We used to it in angiographies and all those things. The bad part of it is that you're converting all this wonderful three-dimensional data into a two-dimensional en-face image. You're superimposing blood vessel layers and you lose depth information. This is an perfusion. Vessels at different layers appear to be merged, and some of them seem to have anastomosis because you're looking from the top and you're superimposing. We'll quickly go to the main artifacts. This is thing. Whenever you have imaging, there are rules of imaging, and whenever there are rules of imaging, you will get image artifacts. The first one we'll deal with is low signal strength. Signal is the information you get from the eye, and noise is the damage you get from the system. So whenever there's a decrease in media opacity, the signal comes down, but the noise doesn't change. You get an altered signal noise ratio. And whenever the noise is too much, you end up getting something called snow. Uh, Many things like even cataract in a dry eye can affect signal acquisition. What do you mean by localized loss of signal? When you have a media opacity or something in the media, this is quite interesting. It doesn't affect the incoming light beam. It is more affected by the outgoing. The backscattered OCT is affected by all these opacities. They are not collected efficiently by the OCT interferometer. And that is why you get defects like these. These are loss of signal. Another loss of signal you can see in this particular area over here. You can see there's loss of signal over here. So the other thing I'd like to talk to you about is movement of the eye, artifacts due to movement of the eye. There are two types of movements. One is because of gross movements of the eye, and the second is within movements within the eye. And artifacts can be due to either movement or the machine correcting the movement can cause artifacts. A white line artifact. What we mean by a white line artifact is that because of a sudden saccade, it looks like a movement. So you get a white line in between. Vessel doubling and stretching is because of the correction of the movement of the eye. That's a software correction, and you get these. So in this particular, you see these white line artifacts. This is called a stretch artifact, where you see a stretching of the signal over here. This particular one, you can see all the vessels are doubled over here. It's a doubling artifact. And this is called a quilt. You can see a checkered pattern over here. It's called a quilt artifact. So that's what microsaccades produce. But the slow drift of the eyes can sometimes totally cause a lack of clarity. And movements are corrected by two things inside the OCTA, that is eye tracking, or the software does a whole motion correction. An interesting thing is that there are movements within the eye. That is, the choroidal lobules are pulsating. The choroid is not uniform and thick, and all these produce something called Z-axis motion artifacts, but these are usually taken care by the system itself. Two unpredictable artifacts that actually look like motion artifacts are decorrelation or reflection from large deposits of lipid deposits or hard exudates can produce decorrelation and a bright spot, or the walls of a cystoid macular edema can also produce artificial vascular markings. One of the most important artifacts is the projection artifact, or also called decorrelation tails. What happens when the light passes through a blood vessel can cause it to reflect back, absorb, refract. And the deeper structures are illuminated by this altered light. And therefore, you get an image on that. So for that, you need a lamp, like any projection system, you need a lamp, which is any retinal vasculature or any chorea capillaris, and you need a screen. That is a highly reflective layers like the plexiform layer and the RP. So this is what light goes in, some of it is refracted, some is attenuated, and some of this is reflected back. But what happens is that this altered light produces an image on the next available reflective surface of the projection screen. And what does this mean? You have superficial vessels over here, and you see this image persists in a deeper layer. And here on the structure flow correlation, you can see the imprint of the vessels seen in much deeper layers where you know they're not there. There are many ways around it, like subtracting NFAS images or something which is new called projection resolved octa. But essentially, I just want to show you these are certain softwares, the projection artifact software. You can see this, and when you put the PAR off, you can see the blood vessels on the same scan. Again, we're removing the blood vessels and with the artifact removal not on. Most important is, as personally, you have to understand whether an image you see is a projection artifact. How can you do that? By taking various layers and checking whether the persistent defect is present in superficial layers or deep layers. You can correlate with your flow, structure flow correlation, or you can just plainly look at the structural OCT to see if there is any vascular object correlating with that point. Segmentation artifacts, that is what the machine produces segmentation, it doesn't go in the right layers and you don't get consistent vascular information from that. In myopic eyes, you can see the segmentation is all ORI and you get all these strange vascular patterns. Also, if you have here, you see a thick slab which is going through sub-RP space through the RP and through the retina and the SRF, and you cannot make an interpretation properly as to what the NFAS picture shows. Also, the slab thickness, you can see with the variation of slab thickness, you get huge vascular lesions. When it's thin, you get small vascular lesions, and it all depends on where the segmentation lines go. Another patient where you cannot make out abnormal vasculature from normal choroidal vasculature from a scar because the segmentation is all over the place. So I'd like to go through the final part, the nuances of octa recognition. We'll just go through these quickly. This is a very interesting picture. Any lesion, it all depends on where you take the segmentation. The lesion can look bigger, or if the segmentation, it can look smaller even. So this is a sequence of pictures where you can see the CNBM over there, different sections produce different images, different sizes, and there is a likelihood that you could get totally confused as to the size of the lesion based on where the segmentation goes. This is another picture where you can see the same branching vascular network in 3 different cuts, 3 different intensities and sizes, different speeds. As we mentioned earlier, the OCTA can only pick up a particular threshold of velocity of the RBCs. So here, this is one of the typical, the microaneurysm is a typical lesion to show the limitation of octa. You can see a lot of microaneurysms here, but you don't see any lesions in the corresponding OCT angiography over there. Relearning how to look at vascular lesions, as we've got to relearn how to look at leakage. So this is a typical FFA we're all used to. There is no leakage. As you see, there's no leakage on an OCT angio. You just see the vascular elements. Here you would presume a lot of leakage in this area if it was an angiography. Here you just see the collateral formations and a large cystoid macular edema. Acquiring the best image. This is what we like to do. I'll just go through this. Always start with an infrared reflectance image. Know that the eye surface is moist. Know the area of interest and keep the RPE as horizontal as possible. So this is an image which was taken and you can see that you can hardly see anything in the, this is a defocus image. You can hardly see anything over here. But then you take an IR image, make it crystal clear, the image crystal clear, redo the octa, and suddenly all the layers come clear. Why? Because the defocusing is a main issue in not getting good images. Again, select the best slit, use a thin slab to pinpoint your location and increase the slab width to get more data. So this is a case where you see there's a lesion, you can't make anything out, a very thin slab and you can see the vascular lesion over there. You slowly increase the slab width over there and you get the entire extent of the lesion for quantification and qualification. So I'm just going to skip this. And then how do you correlate? Every image, as I said, comes with a structural, the cross-sectional, and 2 octas. You have a beautiful lesion over here. And then with the cross-sectional structure flow correlation, you see a circular lesion with flow inside it. Another, you can see a widened FAZ. When you look at the OCT along with it, you can see a large cystoid macular edema hanging over there, probably pushing the vascular layers and creating a false large FAZ. This is a wonderful case of a very interesting patient with a neovascularization elsewhere. You can see it on this is above the retinal surface. The next one you can see, you can still see it over here, but this is the most interesting. This is an RP slab where you can see a projection artifact just because of this particular lesion on the top. So looking for the projection artifact, as I say, there are 3 things you should go through just to know that there's a projection artifact. I think I'm going to we'll just go through the different plexuses. We have the superficial vascular plexus. A lot of features about it. It's a regular spider web appearance. Capillaries arise and they drain into the venules. The importance is that they all come like a centripetal pattern to the FAZ. You have your intermittent and deep capillary plexus together. They call the deep vascular complex. It needs projection artifact removal to visualize because the superficial vascular plexus impinges onto it. The intermediate is at the plexiform border, and the deep is at the other plexiform border, which are both high metabolic areas. And these are the two areas that produce high reflectivity for projection artifact also. And then this particular plexus, the radial peripapillary plexus, it is probably a birth child of the octa visualized by octa beta and not seen on FFA. And this is how the essential plexuses look like. The FIZ is very interesting because the newer and newer concepts say when you want to measure the FIZ, you have to have a whole retinal thickness because all the three plexuses converge at the FIZ, and the best way to measure it is take the whole retinal thickness. The choriocapillaris is a granular layer. It has ghost vessels also, but there's a concept of signal voids which do not correspond to empty choriocapillaries. They are an imaging pattern. The satellars and halars will appear dark, and you can see them only as you see in this particular patient, this particular image, only when there is atrophy of the RP, you can see the vasculature of the RP. This is because the flow is attenuated. So I think I'm done, and thank you for a patient listening, and I hope some of the things have been clarified regarding the basics and nuances of OCT angiography. Thank you.